Good thought, PMR for old TB. Good. Excellent. Good thought, PMR for old TB. Fibrotic. Okay, good. Good. You guys have made all the findings. The diagnosis is a little bit different. So what I'm going to tell you is, yeah, PPF is an excellent thought. Whoever said PPF is an amazing thought. You need to have differential when you see mid to upper lung predominant fibrosis. We all know lower lung predominant fibrosis means we are going to call our usual suspects idiopathic interstitial pneumonia that includes NSIP, UIP, and its cousins. But when you see an upper to mid lung predominant fibrosis with evidence of volume loss, the differentials has to be, as you guys mentioned, TB, progressive massive fibrosis, other pneumoconiosis, radiation, patients who have head and neck cancer and who underwent radiation treatment, that also needs to be considered. The other important thing which many of the people forget is ankylosing spondylitis that can also cause upper lung predominant fibrosis. And the most important thing when you say mid to upper lung predominant fibrosis, sarcoid. This is a patient who has sarcoidosis. Let me show the CAT scan. So that's what I want you guys to take away from this case. Mid to upper lung predominant fibrosis, always have 3 to 5 differential diagnoses in mind. And let me show the CAT scan of this patient. You can see there is a conglomerate soft tissue within the mediastinum, and you can see how the left atrial posterior margin is buckled up and pushed anteriorly. And you can clearly see there is clear areas of traction, bronchiectasis, architectural distortion, and biapical cavitary lesion. This can happen in sarcoid, and these cavities can get seeded with aspergillus, and aspergilloma can occur. The other important point, when these patients who has like history of chronic sarcoid and in the fibrocavitary stage, the important thing you guys need to look for is the prominence of bronchial arteries. You have to mention this in report when you see prominent bronchial arteries, because this will keep the patient on watch list. And also this patient who is having bronchial artery hypertrophies are at high risk for pulmonary recurrent bleeds and recurrent hemorrhage. So always mention it. The other important finding when you have chronic sarcoid is look at the pulmonary arteries. In this patient, the pulmonary artery is dilated until 4 centimeters, and the aorta measurement is 2.8 centimeters. So definitely pulmonary artery is big. Many times I have seen people just mention, okay, dilated pulmonary artery suggestive of pulmonary hypertension. You are unnecessarily sending so many patients to echo just by calling that as pulmonary hypertension. So when you have a dilated main pulmonary artery, always check the corresponding aorta to look at the measurements. If the aortic diameter is smaller and the aorta to pulmonary ratio is greater than 1 centimeter, then you can call pulmonary hypertension. If not, just call dilated pulmonary artery. In this patient, you can see because of the fibrosis, there is chronic pulmonary hypertension. And as well, when you scroll down within the cardiac parenchyma, you can see how much the right ventricular wall is thickened. There is right ventricular hypertrophy and also right ventricular enlargement and right atrial enlargement as compared to the left side. And possibly this patient is having some mild flattening. This implies the patient is having RV overload as well. By looking at all the findings, you are giving the diagnosis of fibrotic sarcoidosis with bronchial artery hypertrophy and also giving a sign of pulmonary hypertension with RV overload. This implies the patient needs to be hemodynamically managed urgent cardiology referral, because this can cause acute heart failure as well. So always be vehement of it.